Hello, everyone. Thank you so much for joining my webinar. Of course, I'm Barry. I'll be the biologic coordinator and medical assistant doing this presentation today. And basically, I don't know if you were able to join the webinar last week, but again, we're going to be kind of focusing on that next level skill of who gets seen and who gets treated, just talking about accuracy and accountability in dermatology with kind of more of a specific focus on HS. But I'll go over a couple of things and then we'll get into the presentation. So I wanted to mention the BCOD conference that's happening November 6th through 8th at the Omni Hotel, the new one in Fort Lauderdale. I'm really excited about this conference, A, because it's on a weekend, and a lot of us know what it's like trying to attend conferences during the week, especially us BCs, because not all of us work from home. I'm in the office as well. So it's a really great place for resources, mainly networking, which is the biggest thing that I got out of the presentation. I went last year and I was a speaker there, and it opened up so many different avenues of being able to help me get different access for patients, working with pharma. There was just so much that I was able to obtain going to BCOD. So you guys, please check out our website if you'd like to go. All the details are here again, and it's on the website as well. And it's even, I like to also tell people too, because a couple of BCs have reached out to me and said that they would love to go, but that their practice is not supporting them. So please reach out to Kristen. She will be able to help you as far as being able to get some information and the scholarship fund. They can definitely help you with accommodations. So don't feel like you're lost out if you're not able to actually afford to be able to go to the conference. And also presenting. So kind of like I was saying before, if you've whether you've presented before or not, it's a great way to really take some topics that you might be interested in and being able to put them out there to a platform to just be able to encourage some conversations. Myself, obviously, all started from doing this last year, and now I'm doing these webinars and really able to talk about things that I absolutely love doing. So if you have any questions, you can reach out to me. If you want some pointers when it comes to just navigating and talking about certain issues, I'm always here as a helping hand to anyone that might need it. So what we're going to be talking about today, and essentially when we're talking about this, who gets seen, who gets treated, this conversation is a really important one, especially to me, because, the accuracy does determine the outcomes when it comes to these clinical trials and how we're able to see patients. That evidence does shape the access, and that representation shapes the evidence. So let's kind of start with the accuracy part of this. So when we misrecognize disease or misunderstand severity, that treatment timeline kind of shifts and that escalation gets delayed. And then the patients live longer with the inflammation. And why that really matters is because those in dermatology, those small delays really compound. And that evidence kind of shapes that access, like it says here. And that data that we generate in the trials, it doesn't just live there. It starts to become part of that insurance criteria. It becomes part of the step therapy language. And obviously, as BCs, that's what we're doing, and that's our main focus and a part of our job. So it really does become the framework for what is considered medically necessary. So again, if certain populations are underrepresented or underanalyzed, the average patient does become skewed, and that affects how we confidently will escalate that care. So using HS as a case study. So we're going to say disproportionate prevalence in Black patients, earlier onset in many women of color, and later specialty access. So the disproportionate prevalence in Black patients in that earlier onset, that's really the biggest thing because large US data sets show that Black HS affects Black patients roughly. Oh, sorry, I hope that this screen didn't go away. I'm so sorry. Just one second. Let's see. Let's see if this is going to work again. Sorry. Okay, here we go. Hopefully that works. Um, so yes, those US large data sets that affect Black patients roughly 2 to 3 times the rate as seen in white patients. So when that prevalence is higher, the research really isn't proportional, and that base is incomplete from the start. And so when we talk about that earlier onset, that's also critical. So when the symptoms begin younger for patients, but then the specialty care happens. Oh, I'm muted. Just one second, I'm sorry. Can you hear me now? Just want to make sure. Okay. I think everybody's saying that they can hear me. You can just put it in the chat. Let's see here.
I can hear you on my end.
Okay. So I'm going to try doing, okay, it shows on mine that I think it's working.
I think you're
Okay,
good.
we're good. Okay. Here, let me get back into this here. All right, so kind of going back into that earlier onset in many women of color, especially because women of color, Black women, do tend to be the highest proportionate or disproportionate when it comes to not only just the onset, but then, how the disease is kind of accumulating. So when the symptoms begin younger, but the specialty care happens later, that's what starts to really accumulate. So what you're going to deal with is you're going to deal with more scarring, more sinus tracts, more advanced inflammatory involvement. And by the time someone reaches a dermatologist, you're already kind of beyond that point of really trying to get diseases under control and kind of putting methods into it that aren't really going to help as much later on. So let me get here. So how this influence works in dermatology. So the influence is cumulative and that chain reaction where the changes occur across multiple domains, which then the structural shifts precede the data shifts. And what that means is the influence in medicine doesn't only mean the publishing trials, it also includes the referral patterns or the CME content, which is kind of that continuing medical education. When we're looking at these things inside of, the textbooks that providers are saying, a lot of these things do tend to show a lot of things focused on lighter color skin. So if we're not including those things like how the disease is framed and how the clinicians are trained, that's where we kind of start to see that kind of decline in how the patients are able to be treated when it comes to patients of color and those structural shifts kind of preceding the data shifts. So when the access spans and when the disease is reframed, and then when the education starts to evolve because of that, that's when the research really begins to show up. So in what we consider normal and how comfortable we feel, in escalating therapy. So this is actually one of the key things that I really am excited about addressing in this when we're talking about Theodore Lawless, and him expanding the field and what he did. So he expanded in specialty care, strengthened that dermatology within Black institutions, and also broadened that clinical exposure. And so I didn't get a chance to elaborate too much in the last webinar about exactly who Theodore Lawless is. So I wanted to give you guys a little bit of an update on exactly who he is. He was a dermatologist and a philanthropist who built one of the busiest dermatology practices in the country on Chicago's South Side. And he was treating thousands of patients a year, and many of them who couldn't pay. And because he was kind of doing this during, legal segregation when Black Americans were systemically excluded from quality medical care, he didn't wait for the system to change. He kind of built access where nothing existed, which is kind of where I am when I think about my care as a BC, as a future PA. I'm really thinking about these patients in regard to being able to make that change, being able to affect that change, even though these things aren't in place yet. And that reframing is really what clinically matters. Um, he really understood that distinction and named it clearly at a time when most medicine didn't. So he was also, a lot of people don't know this as well, he was also the first African American certified by now what is the American Academy of Dermatology. He was first established in the clinical laboratory side for dermatology at Northwestern. He published research on conditions that disproportionately affected Black patients at a time when that same association kind of barred Black physicians from membership. So he's someone that is such a big icon to me and has really done a lot of driving force that allows me to be able to do what I'm doing now. Um, and recognizing that disease burden following the exclusion and not biology, naming what others won't, documenting clearly, escalating, things when the evidence supports, those are things that are just, again, the pushing and the drivers. And one thing that I wanted to also note was that his legacy runs directly through Skin of Care Society, an organization founded by, in part, Susan K. Taylor, who you'll see all over my deck here. I have a lot of quotes from her. When I was doing a lot of research when I first started to get into clinical trial advocacy, she was someone that I was watching a lot or seeing a lot and listening to her quote. She was also such a good inspiration for me. So to know that it kind of intersected that way was something that was absolutely wonderful for me because dermatology is built on pattern recognition. So the more patients you see, the more complete you understand, it makes it easier and strengthening the dermatology within Black medical institutions and really creating that community. So the diagnostic blind spot. So this is the medical education that's centered on lighter skin, how that inflammation presents differently in pigmented rich skin, and the delayed recognition, the worsening of the outcomes. So it was kind of like what I said in the prior slide. When we get into that education that's centered around that lighter skin, you know, everything has been to lighter skin for such a long time, which has really created a lot of blind spots. So that erythema, inflammation, all those pigment changes present differently in darker skin. So when the recognition improves or when people are able to kind of see more how that presents, that's how the outcomes are really going to improve. So that's earlier diagnosis, shorter time to escalation, and less cumulative damage. So I always talk about this patient who I saw multiple times. She came into the clinic, and when she first came in, the biggest thing that she told me was that this was her fourth dermatology clinic that she had been to in the last 6 months. A, because it took so much time to get in to see someone, and every time they would treat her, they were mainly focusing on the fact that this just looked like pigmentation. It didn't look like any sort of an actual diagnosis of some sort of like chronic skin condition. So by the time that she had came to our clinic, it was so bad that her skin was just overreactive, tons of hyperpigmentation. Her skin just looked awful. So it was one of those things where if the providers were able to understand what it looks like on darker skin tones, then she would have been able to get care a lot more efficiently and sooner. So when we're talking about HS from the minimization to kind of the recognized inflammatory disease, that's historically minimized in clinical language, disproportions of burden in Black patients, and then also the inflammatory recognition and changed escalation. And one thing I'll say, kind of going, I'll get back into the smoother things, but I always want to make sure that I don't forget to say that because of how that pigmentation presents on darker skin, the psychosocial burden that that does give for a lot of darker patients or patients of color is something that you should really try to put in your clinical notes whenever you're doing these prior authorizations, because that will make a huge difference in how things do get treated and do get delayed. And I think I've mentioned before, if I didn't, using clinical trials, not just in appeals, but also using them in your prior authorizations really does make a huge difference. I had a patient last week it wasn't for HS, it was actually for medical Botox. But I like to use this as an example because it's not on her formulary. It was for the palms and it was for the palms and in the forehead, which a lot of insurances really do consider experimental. So every time I was trying to get it, it just was getting denied, 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 denied. But when I put on clinical trials that show how this works, even though it's not FDA approved, I tagged a whole bunch of them there. The insurance actually wound up approving it, which was a huge win because it took me like a good solid 3 months to get the insurance to do this. So when you're presenting these things and you're not sure exactly what to put beyond like photos, please use those clinical trials. Go to clinicaltrials.gov. You can even use Google for that. If you type in Google, like, have there been any studies done for HS patients or for whatever it is that you're looking for? A lot of those things will be on NIH or clinicaltrials.gov. Use those things, and then that way you're able to kind of get those things to prove that you didn't think that you wouldn't. Okay, sorry, kind of backtracked a little bit there. We'll get back into kind of talking about um, the historically minimized clinical language. So because of that disproportionate burden within the Black patients, the inflammatory recognition does change the escalation. So HS is usually described as recurrent boils or follicular infections or hygiene related. But if this disease is disproportionately affecting Black patients and it is simultaneously minimized, those kind of stigma compounds do delay. So it's really about how you shape that urgency, and that really will help those things get covered for your patients. So the recognition of HS as a chronic inflammatory condition is really the key to really changing that. And also kind of talking about pain, which I'll move forward to here in a minute in just a next slide. But in practice, this kind of it's justified the systemic therapies and it justifies these biologic trials and aggressive escalation when it comes to these patients of color and getting improved access. So the pain and scarring, and this is really the key for what the trials miss because the pain is under prioritized, hyperpigmentation persists, and the lesion count really dominates the endpoints. And that's the biggest thing about HS is that pain is one of the most disabling features of the HS, but yet in clinical trials, the lesion count tends to really dominate what the endpoints are for them. And that really matters because what we measure becomes what we treat. So if you're kind of prioritizing how many lesions they have, and that goes for a lot of conditions, even if you're thinking about something like bullous pemphigoid or excuse me, prurigo nodularis. When you start thinking about that situation, for them, it's much more about the lesion count of the things versus how much the pain is in, how much they're itching, how much all of this itching and scratching can then cause hyperpigmentation. So it's kind of one of those things where it just starts a snowball effect. And so also post-inflammatory hyperpigmentation, which we obviously all know can occur across all skin types. But however, in darker skin tones, the pigment changes are often more visible and they do persist longer due to the melanin activity. So even when the nodules resolve and the inflammation decreases, the visible pigment alteration in scarring can remain. So by, a standards of a trial or by what insurances may say, that may be considered improved, but this is still a huge, I use the word cosmetic loosely, but it's still a very huge, cosmetic and kind of a psychosocial burden on the patients. And specifically for a lot of Black patients, what we see, how this looks in our skin. I've had my versions of X-Men, things like that. And the scarring and the pigmentation that those things can really leave behind, it affects me long after because people look at you, think that there's something wrong. Why does your skin look like that? Things of that nature. And it really does kind of place that burden on you mentally. So it's about really recognizing that the disease, does present differently and that our endpoints don't actually capture that nuance. And if we don't measure it, then we don't really address it. So kind of talking about the intersectionality gap here, which is that race and sex are always analyzed separately. Black women are underanalyzed, and the highest burden it limits that intersectional data. So when Black women sit at kind of this intersection at the highest prevalence and the highest burden, that's where things are the most accent, and that's why that group becomes more statistically blurred because they're analyzed separately. They're going to focus on one thing more than the other. They're going to focus on the disease state, but they're not looking into the factors of how Black women sit there at the highest. So they're the most affected. So that's where we're starting to see it show up in that evidence and in that confidence. So that's something that we really do have to address. So the diagnosis accuracy starts here. So it's recognizing that presentation differences, documenting that severity clearly, and again, naming pain explicitly, which is something that I really pushed at my last webinar, and I'm really pushing at this one. And that specific part of it, that goes for all skin types. Because while HS does have its more prevalence among Black patients, and those higher disproportions, HS still is the same for every patient. So they're going to be dealing with a lot of that pain and making sure to include that in our prior authorizations, and in our chart notes especially, is really, really important. Not just saying that it affects a patient's quality of life, but it's also affecting how they can't sleep, how much this is affecting them, their sheets, all of those things. I like to go detail when I'm dealing with these insurances. I don't really like to try and keep everything super clinical. I'll talk about that. If the patient's telling me that they're having to buy different sheets because they just can't stop with, the rupturing, then put all of that in there because all of this long term is really affecting the patient. So if the severity language is vague, then the escalation is kind of harder to justify. So that's really what the point is about that, delayed recognition, and it really compounds that inflammation. So naming that pain explicitly ensures that it's acknowledged in treatment decisions for the patient. So documentation, which shapes the access, which goes into the trial endpoints, which goes into insurance criteria, like we discussed. The severity language does drive approval, and then the documentation does become evidence. And so we all know that, or maybe some of you don't know, that insurances, they will mirror trial endpoints. So, once these clinical studies are done for these various drugs, then the insurance is going to look to that to see, well, what are the criteria that we're going to use to get these things approved for patients. So that severity language really does become the bridge between the lived disease and the approval. So in the prior authorizations that we're doing, and the reauthorizations and the appeals, the documentation really does become your evidence. And so now we get into the escalation and accountability. So again, that framing determines the urgency. The accuracy is what really protects the patients, and the accountability strengthens the dermatology. So obviously, we know we talked about in slide 6, kind of that reframing. This really does drive that point home because the undertreatment does lead to cumulative damage, and the accuracy protects the patients from delayed escalation. So accountability really strengthens dermatology because it ensures that our evidence reflects the reality. So in outcomes, in fewer years lost to uncontrolled disease, that's what's really going to happen once we start kind of putting this escalation and accountability into effect. So what do we do with access? So access is influence, precision is responsibility, and outcomes are not accidental. So access in dermatology isn't really something neutral. Access to research, to treatment, escalation pathways, leadership spaces. Access really does shape who gets seen and who gets treated. And precision matters because documentation drives approval, language drives urgency, urgency drives access, and access determines who receives advanced care and when. So when we align evidence with reality, and when we name pain clearly, when we document severity accurately, we aren't just completing notes, we're going to be shaping outcomes, which is the most important. So this quote that I had wrote at the end, right before I presented my last presentation, when I was sitting there going over my notes, I really wanted to write something impactful because all of the men and women of color that I've mentioned, and the doctors and providers, they always have something so powerful that moves me, and which inspired me to write, the work of those before us open doors. What we do with that access, how carefully we practice, how clearly we document, and how boldly we escalate determines whether outcomes change. And that is just such an important key takeaway from everything that we all do. So I think having good inspiration, like the things that I've mentioned in this, really does help me keep my patients, together and just get to do what I love and enjoy. So I wanted to make sure I didn't do this in my last slide, but I wanted to make sure that we had some resources for patients. Because with everything that we're talking about, especially within certain communities, there's not always resources for the patients to be able to have. So I've got a list here. I'll leave it up here for a minute if anybody wants to take a couple of quick photos of just some really good resources for HS that patients can reach out to. Some of them are specifically for patients of color. Some of them are just some nonprofits and patient-led communities that are really great to be able to give your patients if they do have any questions or just want to know where they can reach out to. And when I was going through a lot of these websites, I was going through their forums. If some of you have the time to actually check them out and see what these patients are talking about, they're all kind of talking amongst each other and kind of really trying to help guide each other and give each other some good advice when they're kind of dealing with the burdens of HS. So please reach out. And you can also find some really good resources that you can use for your prior authorizations, and not even just with HS, but if you have any patients that are skin of color with, acne or any sort of, just a debilitating chronic inflammatory condition of their skin where it's left a lot of scarring behind their pigmentation and they want to know what they can do about it, give them this information. I assure you, they'll thank you for it. And I just wanted to mention here that our upcoming webinars that we have one on Tuesday, April 14th, which is just kind of a check-in series. And then also on May 12th, which is just the BCOD cracking complex cases. So please check those webinars out. They're fantastic. Let me go back here. Actually, I'll leave this up and ask, does anybody have any questions? I can pull here and see. If anybody has any questions, please feel free to ask. Let's see.
I think we're all just discussing. I don't know, Barry, if you can see the chat.
Oh, let me
We're
go
all
back
just
up.
discussing back and forth in the chat the whole time.
Oh my God, yes. This is so great. Yes, that is a really good one, Amy, that Amy said that the MSLs do sometimes have access to the trials. Actually, my first presentation that I did with BCOD, how I was able to do that presentation was I went to, sorry, you guys, my cat is over here meowing like crazy. Um, I had asked a rep for Janssen if there were any clinical trials that had been done for skin of color, and she didn't have an answer at the time. But she said, well, let me link you up with my MSL and she'll give you some information. And that's how I was able to get information on the Visible trial. And that just slay rid everything that I started to do and got me to where I'm at now. So definitely ask your MSLs and your pharmaceutical reps. Let's see.
I have something to share regarding HS. I have a pair of twins that
Mhm.
actually are identical twins, and they both have HS. And they've both tried Humira and Cosentyx. One
Mhm.
has tried Bimzelx and has had some improvements, but isn't at goal. And I
Mhm.
was able to get the MSL to send data for Rinvoq, so we're trying to get her approved through my AbbVie Assist to
Oh,
see
that's
if that's available.
wow. So I mean, obviously it would be an off-label use, but I've been hearing a lot about that with JAK inhibitors. And
Hmm.
they want to have somebody. What's that? I thought somebody said something, sorry. Um I was just reading about that also too with even Opzelura, which I had no idea that there were even trials being done about that. But when I
Hmm.
was in the middle of doing research about something else, a clinical trial popped up for that, and I was like, wow.
Yeah, it's being studied right now for Opzelura, but you can check with the MSL. There is data regarding Rinvoq being studied as well.
I'm
Mhm.
gonna have to share that with my provider. She sees a lot of HS patients, and so that's not even something that I knew specifically for Rinvoq. I'll have to look into that.
Hmm. Yeah, and it would be the 15 milligram.
The 15 milligram. Okay. Did you know if they did any data as far as like if it didn't work at the 15, raising up to the 30 milligram once daily?
I'll be honest, I hadn't had a chance to look that deep into it. The
Hmm.
studies that I did see showed that there was some improvement with the 15 milligram.
Okay.
So given that we're doing every other week dosing with the Bimzelx for twin one, I'll say,
Mm.
um, the provider's wanting to skip Bimzelx and go straight to Rinvoq just so that she doesn't have a delay in appropriate care.
Yeah.
Mhm.
I wanted to ask I, I I don't know if Tammy's still in the room, but she was saying, what is the number one thing we as BCs can do to better help this get better? I think it really is just kind of the educating ourselves and things like this. Like this is what we do. I've gotten really big into just watching a lot of webinars from other BCs and really paying attention to the things that you guys are saying and jotting notes down because I'm always finding a good little piece of information that I didn't know before I started. So Definitely continuing to reach out to other BCs and networking and asking questions. I'm never afraid to do that. So that's another really big key. Amy's in the room, and Amy is somebody who I've learned a lot from reading her blogs, just paying attention to things she says. So again, it's the resources of really listening to other BCs that can really help you out.
I do have a question. It's off topic for HS, but
Mhm,
since I have a captive audience, I was wanting y'all's impression. I have a patient with pustular psoriasis,
mhm,
and she's done well with Spivigo, whether it be infusion or maintenance with IV therapy.
mhm,
She has a commercial insurance plan which has approved the medication,
mhm,
but she can't afford the medication, and her income is above what TAP will qualify for. I was able to get it approved through the medical plan for
mhm,
her. But I was trying to see my next step was going to be getting with the insurance commissioner for Florida. I did try and get a tier reduction or a co-insurance reduction from the commercial payer, and they
mhm.
declined. And I didn't know if anybody had any ideas, with this being a critical condition, if there's something that may be a good idea.
And you said that, wait, you said you had or had not appealed it yet? I'm sorry.
So the medication was actually approved,
Oh, it was approved,
but
and then
but she has a 50% co-insurance on her pharmacy plan,
right.
and the cost of the medication is 45 grand per kit. And then the infusion would go through medical, or I can get the syringe covered under medical, billing it through a specialty pharmacy. But she would still have to meet a $9,900 deductible for the year, which quite honestly is steep. So I didn't know if anybody had any ideas.
Have you shared this information with the FRM for the drug company yet?
I have. We've been trying to troubleshoot different organizations, to apply for grants, but most of them are out of money. And the copay card that she would be issued would be insufficient funds to cover what she would need for the year.
Yeah, I mean, because you said what, 45 grand? Yeah, that's wow.
Yeah.
That's a
I
lot.
haven't.
What about an infusion center, or can she go to a hospital, or is she commercial insurance?
So with the drug, she can only be infused if she's in an active flare, which she needs maintenance therapy at this point. I did argue with the plan that mitigating flares would lead to disease progression, and she could be hospitalized if she's not adequately controlled or have sepsis or organ failure. But they still declined.
That's crazy.
Yeah, that
Mhm.
is.
What insurance is it? Do they have, I know you said that you kind of appealed to them. Do they have a
Yeah.
medical necessity hardship program?
So it's blue, and I sorry, we're on course terms. I actually found a form that I had never seen before. First, I did a coverage exception, which they denied, and then they sent me a. It's called a DAW, dispenses written member to pay the difference waiver. And essentially, what they explained to me was, say I'll use a blood pressure medication as an, example. Say the medicine that is approved is a tier one versus a tier three is what you need. They'll let you pay for the tier one price versus tier three.
Mm-hmm.
With this drug, there is no alternate medication because it's the only one that's FDA approved. And they said they would actually look at that with all of the documentation that I submitted, but then they prefaced it's almost impossible to get the payer to decrease the co-insurance responsibility because it's like their contract with the member,
Mhm.
and they refuse to overturn that. So then my recourse is, well, I really believe she should have access to this medication. So I asked the patient to write a testimonial letter.
Yes.
Um, and
Mm-hmm.
then I have a letter drafted to the insurance commissioner, and I've had her um, told her to sign a medical release so that we could do it.
I
Hmm.
agree with that plan of action.
I agree with that.
Okay. I have no idea how long it will take. After I told her all of that, she told me, she said, well, I spoke to my husband and, it would be really difficult, but if I have to pay out the $900, we will. And I just feel bad knowing that, they have a single income household and this
Yeah.
is a really big chunk of money for her to have to pay out every year.
Hmm.
What
Yeah, I
foundations
would
have you
definitely.
or tried to go through, I would say?
Can you repeat that, Barry?
Sorry, I was just curious what foundations, because you said that there were a couple of foundations that you were trying to kind of potentially go through for like grants or support.
Mm-hmm.
I was curious
Mm-hmm.
which ones you've used thus far.
So there's a wait list for the assistance fund, which is called TAF.
Mm-hmm.
We looked at the PAN Foundation, which that is closed. There's no funds available. Looking at the Rare Disease Foundation, and then there was a third one or fourth one that I can't recall the full name, but essentially it was access um, for rare disease program, and I have them at the office, and I can share it with you guys over text. But that was essentially all I could get, and of course, that's application process is not necessarily immediate.
Yeah. My provider mentioned the one that you already said. I asked her if she knew anything or just anything about grants.
Mm-hmm.
She had mentioned the assistance fund. That was the first one that she had mentioned.
Mm-hmm.
And then, because you said it was pustular psoriasis?
Yes, GPP.
Okay.
True
PPP.
GPP. Mm-hmm.
Hmm.
I'm just going to
Yeah,
ask.
and Sarah, you're right. I mean, there's no other FDA approved medication. So the
Mm-hmm.
fact that she's approved but still can't access it, that the insurance, then they do have to step in. There's got to be a financial exception process or a medical necessity hardship program.
Right. And ironically, she has had signs of HS also, separate of the
Mm.
GPP, which I sent that in the chart note too. But prior to her having the diagnosis of GPP, she had psoriatic arthritis and plaque psoriasis and was on Humira for a long time. And
Mhm.
then she had this new pustular rash, and she came to us because she couldn't be seen with, I'll just say, big center um, clinic,
Hmm.
and we were closer to her home. And fortunately, the doctor that I work for is familiar with the disease process and was able to get her on therapy right after it came to market.
Hmm.
Mm.
Yeah, I'm gonna reach out. I'm gonna talk to so because another one of the providers that I worked for, uh,
Mm-hmm.
Dr. Jenkins, he has a lot of contacts within the realms of psoriasis. He did a lot of research in the clinic that I worked in. He had his own separate
Mm-hmm.
research facility separate from our actual medical clinic. So
Mm-hmm.
he's pretty well versed and he knows a lot of contacts and things of that nature. So I just sent him
Mm-hmm.
a text message. When he gets
Oh,
back to
cool.
me, Sarah, I'll reach out to you and hopefully some of the information he can offer can give you some sort of a
Yeah, that'd be
outlook on
great.
where to go. Yeah,
And I'll
absolutely.
put my number in the chat. Feel free to reach out.
Absolutely. Okay, let me make sure. Does anybody else have any questions at all about anything before we end? Okay. Well, thank you everybody so much for joining this webinar again. I always love talking about this. This was a lot of fun. You guys had so much great input, so I really appreciate that. Let's see here. Oh, perfect. Thank you, Sarah. I'm gonna
Night, guys.
I'm gonna save this. All right, you guys all have a great evening.
Great job,
Thank you,
Barry.
Barry.
Thanks, you
Thank you
too.
so much. I appreciate it.
Bye, everyone.
Bye-bye.
Bye.
Bye bye.